Now we'll move on to a slightly different aspect of treating keratoconus, that is aiming to treat for vision. And we have two talks. One is a pre-recorded talk by Dr. Vikas Mittal about stromal keratophakia, and I'll be speaking about a new way in which we can actually potentially avoid keratoplasties in patients with keratoconus. Keratoplasty in keratoconus, and obviously that is something that all of us would like to do. So I'll start with a case, and this is a patient which many of us would be familiar with, a patient who has good vision in one eye, very poor vision in the second eye, in the left eye, and with spectacles, the vision really does not improve. Vision improves with contact lenses to 20/40, but this is a patient who's unwilling or is intolerant to contact lens use. And the topography does show that he has quite steep corneas and also very thin corneas as well, putting him in the realm of the gray zone about what should be done next. He also has the typical features you see on the OCT, that he has quite a lot of ectasia as well as steepness and very thin epithelium just overlying the cone as well. So typically, if a patient like this presents who's not amenable to wearing contact lenses, and potentially cross-linking is not going to be of any advantage because his vision is also going to be poor after surgery, they fall into the category where you will consider doing a keratoplasty. You will probably do either a PK or a DALC for this patient, especially because there is no other viable alternative, probably maybe except Intacs to a certain extent, that will improve his vision, but even then he'll probably have to wear contact lenses. So, when you see a patient like this, you have several objectives in your mind. One is obviously you want to improve vision, you want to improve or regularize the corneal curvature, which has to do with improving vision, potentially enhancing the corneal thickness, which again is a side effect of what you'll do to improve vision, and you also would like to prevent progression. Well, all of these can potentially be achieved by transplanting the cornea, and at this point of time, there's no other procedure that potentially ticks all four of these boxes. There have been some reports about alternatives to corneal transplantation, especially from Gerrit Mellis's group, where they have tried to transplant Bowman's membrane into a stromal pocket inside the cornea. And they also have reported that there is a significant improvement in the visual acuity as well as reduction in the spherical equivalent for some patients, but it does not seem to be a very predictable procedure at this point of time. We'll learn more when we look at Vikas's pre-recorded talk. There also have been reports about using corneal decellularized lamellae into the corneal stroma from George Alio, where they found again some improvement in visual acuity as well as some improvement in the refractive error of the eye. There also have been reports from China about using femtosecond lenticules inside the stromal pockets of rabbits to see if they are biocompatible and also to see if they can change the refraction of the eye. Uh, but the problem with using grafts or tissues inside the eye is the fact that tissues do contain some antigenic properties, even though they don't have endothelial or epithelial cells. And there is a possibility of immunological stromal rejection even when you use a corneal tissue of the same species within the eye as well. So we've had some experience with stromal inlays in the past where we tried to put biosynthetic inlays into the cornea to correct hyperopia and presbyopia, and this is going back about 15 years or so. We didn't have great success because most of the inlays that we implanted inside the eye under a LASIK flap tended to become opacified, and some of these inlays also started to have stromal melts because once the opacification happened, the transmission of solute suffered, and so these patients' epithelium in front of the inlay started to melt. So eventually, we had to explant all these inlays. At this point of time, we started working with a company from Germany who was making very precise microkeratomes to shape corneal lenticules for DSEC surgery. And the approach that we took at that point of time was to try and design a microkeratome which is called a nanotome that can shave off corneal stroma from the surface, just like PRK, but without a laser. So, in effect, a sort of a low cost kind of PRK that you can shape the cornea with. We had partial success, but we also had a lot of scarring, so this project did not continue after that. But as a fallout of this project, we also started doing the same thing in eye bank eyes and transplanting this under the flap of patients who had hyperopia. And this was called like. This is a procedure that is still available. And we've been able to correct hyperopia of up to +8 diopters using this procedure. And the hyperopic correction appears to be quite stable over time. But then again, you have a very limited patient profile who will be suitable for this kind of procedure. So these are long-term follow-ups of a patient who had +8 after this like procedure, and it seemed that the stromal lenticule was well integrated and did not have any reactions or rejection episodes after the surgery. So coming back to our patient, and you can see that this patient has visual acuity of 1 meter uncorrected in the left eye, very high refractive error, correcting only to 20 by 200 with spectacles at this point of time. This is when we started to explore trying to put in a porcine collagen lenticule inside the corneal stroma of the patient. So this porcine collagen lenticule actually is pre-treated, it's decellularized as well as it is cross-linked multiple times so that at the end of the process, the lenticule actually becomes quite rigid. And after this, we also looked at literature about using of porcine decellularized material in medical science, and they've been used in several areas in human medicine as well. And we also looked at evidence of lamellar keratoplasty being done using acellular porcine collagen stroma, and they seem to have relatively good success as well. So, utilizing this prior knowledge, what we did for this patient was we tried to create a stromal flap. I'll go to the actual animation, and this is just an animation rather than the actual surgery. The surgery is quite simple. All you need to do is create a stromal pocket. Initially, we used the Visumax laser, similar to a smile pocket. But later on, we started using the FS200 laser, where we could create deeper pockets inside the corneal stroma. And once you create the pocket, this implant was injected inside this stromal pocket and then unfolded so that it actually spreads itself in the pocket and covers the area where you potentially have the greatest thinning as well as the weakness. So the procedure is about a 10 to 15-minute procedure done under topical anesthesia and is also quite simple. So this is the patient we're talking about. This is pre-op topography, 1 month post-op and 8 months post-op. And you can see that the cornea looks relatively clear even at the end of the 8 months post-op visit. And the change in the curvature of the cornea is actually quite surprising. You see, this is preoperatively, you see a lot of ectasia, but post-op with the implant inside the cornea almost regains its natural curvature. And the most exciting part for me, at least, is the fact that regularization of corneal curvature from somebody who has topography K values of close to 80 diopters, if he goes back down to 45 to 48 with close to 33 diopter flattening in the center, I don't think any procedure is able to achieve that kind of flattening in patients who have severe keratoconus. And this remained stable for a long time. Whatever flattening we had at the 1 month visit seemed to be similar at the 8 month visit as well. The epithelial map thickness also seemed to increase, where he had very thin epithelium overlying the cone. The epithelium started to thicken and started to become a little more normalized over time that for this patient. Eventually, this patient with a -11 and a 3.25 preoperatively correcting to 2200 at 8 months, he had a zero spherical error with a cylindrical error of -5, and he was correcting to 2060, which was something that the patient was very satisfied with without having to wear contact lenses at this point of time. So before this procedure, we also applied for CDSCO approval for a limited clinical trial because this was a new procedure that was being done in human eyes to look at safety and efficacy. We included 5 subjects in the trial, and in all 5 subjects, we had a significant improvement in the refraction as well as the best corrected visual acuity at the end of 3 months. We have about 18 months follow up for these patients, and we found that the mean K also had a significant amount of flattening at the end of the trial, and this was probably one of the most gratifying aspects of implanting these lenticules inside the eye. But all did not go very well, and in fact, we had a patient where who appeared to be a very good candidate at baseline. Again, very thin cornea, very steep cornea, and when we implanted the xenia inside the eye, she did well for several months. But at the 3 month visit, she had an epithelial breakdown over the implant, and there was stromal lysis over the implant, and so we had to remove this to prevent any further damage. Post explantation, she did relatively well. The epithelium healed, there was no scarring, and the cornea sort of went back not to the original curvature but slightly lesser than the original curvature after surgery as well. That's the pre-implant as well as the post-implant topography. Very similar before and after, showing that it can be reversible, but we did not achieve the objective after implanting this lenticule. So the question that I get asked the most is, why not use human collagen in the eye? The problem potentially is the fact that in several countries the supply is limited, unlike in some countries like the US and in India. And unless it is decellularized with the same process, the antigenic load can still be pretty high. And so the process of decellularization is probably going to be quite intense and could lead to significant wastage of tissue as well. So once this is optimized with porcine collagen, it can be applied to human tissue as well. And the type of collagen that is used is similar in porcine as well as in human eyes. And because of the immune privilege, we have not seen any immunological or antigenic reaction, even in a rabbit study we did before this, as well as all the human studies that we are doing right now. And with the increased number of keratoconus patients that we're continuing to see, we also are seeing that with the advent of cross-linking, there is a reduction in the number of transplants that we're doing. And hopefully, with procedures like these that can be done in a simple way with just about a 15-minute topical anesthesia procedure, we hope that this is something that can prevent the need for corneal transplants in several of these cases as well. So, in summary, the stromal lenticular implantation still needs to be perfected, but at this point of time, it seems that it does improve corneal curvature and visual acuity and is an option for patients who are not suitable for traditional collagen cross-linking and does have the potential to avoid the need for a corneal transplant. And eventually, I believe that this will form a part of the algorithm to manage keratoconus, where it fits somewhere in between those who are contact lens intolerant and those who require a corneal transplant. Thank you very much.
Excellent work, Praveen. And I just wanted to ask you, in one of your cases, you showed that there was a thinning and there was some. So, if when you're series of cases, if you do a confocal microscopy on them, and what we have seen is whenever we have this nerves and dendrites and all of them being quite differential, your rate of inflammation and corneal melting, because they're all related to the MMP's activities. So whether you can actually prevent in your future cases just by doing this scans, so that you can predict. So those who have higher level of inflammation, poor nerves, can be pre-treated, say with cyclosporin or one of the newer dry therapies, and we can see that a lot of their activities come down.
Right.
So I think that might be, you can use it as one of your protocols in your clinic. Or if you don't, if you have the confocal done on that particular case, that will find a lot of answers.
Yeah, in fact, we have confocals pre and post in all patients. We have looked at them, but I don't think we've looked at it from the aspect of inflammation or even looking at the
Dendrite
nerve
itself.
and dendritic cells as well. That's a good idea. We'll probably look at it.
Because many times when we looked at a short cohort of patients, those who have heavy, lot of haze, lot of this corneal thinning, excessive flattening, all of them had issues, which biomarker issues, which you could pick it up on the confocal microscopy.
Right.
So probably going back and look at those things would probably help, because that is the main nidus of how this activity starts.
Yes, I think we had two patients who had epithelial healing issues or epithelial breakdowns. And common factors that we seem to identify between the two is both had the pockets that were slightly shallower as compared to the other patients. So that's something that we
Yeah.
probably will change. And the other interesting aspect is both happened around the 3 month time point. So maybe it has something to do with the solute
Yeah.
transmission, maybe inflammation as well, and both of them happen in the center. So that
Yeah.
probably tells us that in the periphery it might be doing okay, but the center it's
Yeah.
not doing very well. Yeah, but we'll look at the confocal.
Got.
That's a good
Yeah.
suggestion. Thank you.
One question, Dr. Praveen. How deep do you go with the pockets here?
We went in the initial patients, we did about 120, which was just like what you would do with Smile.
Hmm.
But later we started doing 140 and 150 as well. So we think the deeper the pocket, the better is the effect. But again, these are patients who have central corneal thickness of only about 350 or less than 350. And several of these patients, if you have thick epithelium in the center, you might not have enough stroma to create a real good pocket. So I'm a little scared about going deeper than that. That's why 140, 150 has been the limit that we've gone to.
And do you cross-link these corneas after you put in these lenticules, or?
At this point of time, since the lenticule itself is cross-linked, that is not part of the protocol.
Oh,
But we believe that in the future, after implanting the lenticule, cross-linking might make them less susceptible to corneal melts like you saw in this case.
oh.
So maybe that's something that will come out in the future.
And unfurling these implants inside, is it an issue through the pocket, or
You mean taking them out or?
no, putting them in?
No, it's a pretty simple surgical procedure. It's nothing, no big deal. So
Okay.
any good anterior segment surgeon, I think, should be able to do it with hardly any training.
And the diameter, how much do you
You can
make?
customize it.
Okay.
The ones that we used was about 7.8 to 7.9 millimeters. So you can
Mhm.
customize it to whatever diameter you want.
And the thickness of these implants, how much? How thick
The
is it? One.
initial series of implants that we used were about 70 microns thick.
Okay.
The next series of implants, that is 3 more patients that we did, were 30 microns thick.
Could you use the smile lenticules and decellularize them and then use them in place of these, or?
We thought about that, but there's several disadvantages. One, you don't test for viral markers in smile lenticules, and so you probably would not have that information. You also will not be able to control the refractive power of the lenticule. And also, the lenticules that are shaped that we have right now, they are shaped to have a curvature of 44 diopters. So they actually cut in that pattern. Smile lenticules are not, and that's probably the reason why we believe smile lenticles might not be as effective as these.
And
And
these
the
are
diameter is smaller as well.
and these are pre-cross-linked, is it? These.
Correct.
Oh, thank you.
Thank you very much. So
So,
to go on, we'll
can I ask a question?
yes, of course.
Yeah. So, since we saw up to 1 year follow up, the xenial lenticules, the porcine collagen lenticules, they were not getting populated with the human host keratocytes. So, it also means that it is not integrated into the human cornea as such, but it is just causing topographic changes. It could have its own advantage and disadvantages. Considering that it is reversible and we can still take it out because it's not a part of cornea yet. So how would you see that? Is it like a good thing that it is not a part of the cornea up to 1 year, or do you see it as like a disadvantage in any way?
I think it would be a disadvantage because it seems now that it's hyper cross-linked. It's cross-linked about 20 times the amount of normal cross-linking that you would do for a cornea to prevent progression. So
Yes.
that makes it extremely rigid, but that also probably is making sure that the collagen is so compact that it's not allowing any cellular migration into the cornea. Previous lamellar transplants using porcine corneal tissue have shown some cellular integration into those transplants, and even recombinant collagen that has been transplanted inside the cornea have shown some cellular migration inside them.
Yeah.
Those were not cross-linked. So I think this probably has to be optimized where you need to reduce the amount of cross-linking so that there is some amount of integration and some amount of transport of solutes, and it still potentially can be removed from the cornea like you will do with the smile lenticule in the future as well.
Yeah.
So I think it still has to be optimized, not perfect yet, but this is a very exciting development from the point of view of managing keratoconus. As of now, it's not for sale. It's only research. So depending on the results, we have to submit our results and then look for approval. So we guess that it should be about in a year, year and a half or so. Thank you. We are almost out of time,
Dr.
Rashmi.
Vikas Mittal's talk is 7 minutes.
Okay.
Should I play that?